Hello and a wonderful good afternoon from sunny Bavaria.
Yeah, we have indeed a very nice autumn day today, and we are happy to be with you.
People, welcome, and thank you so much that you dedicate another Friday afternoon to FotoFinder Academy.
And today we have a very special topic. I think we didn't have this up to now, right?
No, I think 3 years ago maybe we did it once.
Yeah.
And people have been requesting for it. True.
Yeah, it's the bridge between dermoscopy and aesthetics.
Exactly. People, I mean, we are going to talk today about photography, the value of photography, not only in dermoscopy and skin cancer, which is our main topic, but whatever is related to treatments, static treatments, trichoscopy, hair treatments. And we have two very experienced speakers with us today.
Exactly. And yeah, they are all international speakers. And the first is coming from Egypt. It's Ahmed Sadek. And he's well known in the field in laser medicine, in aesthetics. He's training doctors around the world. Anywhere you go, he's already there. And today he's not really with us because he's on a plane, but he prepared his presentation, which we will show online.
Guys, you have to know we are in very exciting period of the year. We just came back from the EADV in Amsterdam. That was a big success. Very busy, very good program, also very good scientific program. And we are just prior to the World Congress of Dermoscopy in Argentina. And that's why many of our speakers are at this moment in airports and flying. So Ahmed is in the plane. He told me he prepared a nice presentation, which we will share with you in the next couple of minutes. Our second speaker is going to be Pablo Naranjo. Many of you know him already. Pablo is from Madrid. He's got a very large clinic, the elite clinic in Madrid, that is, in my opinion, one of the best aesthetic clinics in town. And he's been with us for the last 10 years. Personally, I learned a lot from Pablo in terms of before-after photography, in terms of the use of photography, different types of light. He also prepared a very nice presentation for us that he's going to show. I know that Pablo is in a workshop at the moment. He's teaching, but he's going to enter the session as soon as possible, as he's texting with me. And I would say, I see that our team is showing here some information about the World Congress. Those of you who might travel to Argentina, you have the chance to participate in two excellent symposia that we prepared.
Exactly. On day first, it's on Thursday, right? We will have as topic trichoscopy. So the ones who are into hair, you should not miss this one. Tell us a little bit more.
Yeah, it's with Michele Starace, with Ahmed. Exactly, he's gonna be there, and we're gonna really have a patient on stage and do live trichoscopy, talk about clinical photography, trichoscopy photography, how it is best and most efficient when it comes to treatments of alopecia, female and male pattern alopecia. I think it's going to be an incredible workshop. I hope we can get some insights on Instagram. So follow us on Instagram, because you're gonna see some details of that.
Yeah, and they will have great cases, right?
Yeah.
Very special cases.
Exactly.
And the second day, on Friday, we have the big symposium, which is about total body mapping, dermoscopy, AI, workflows, technology, and cases from
Hospital Clinic in Barcelona to Rosario in Argentina, and of course from Naples with Giuseppe Argenziano. I think, to be honest, Catherine, this is for us maybe the event that we've been waiting for so many years. Last time in Thessaloniki, 6 years back, we had a symposium with more than 1,000 participants, and that is, I think, that is the kind of the academy spirit that we get when we are in front of such an audience. I mean, online events, meanwhile, are really giving us a huge motivation for what we do at the level of education. But the live event creates such an interaction, and I love that.
Yeah, we're waiting for this one since, as the COVID has avoided the show, we are waiting since 6 years now to go to Buenos Aires.
6 years now, and the new World Congress of Dermoscopy. People, you will I hope we will see many of you in Buenos Aires. Those of you who cannot travel to Buenos Aires, follow us on Instagram. We're gonna have lives. We're gonna have live instas from Buenos Aires next week. So stay tuned. Very well. Katrin, should we start with the great presentation of Ahmed? Because he told me that he prepared such wonderful cases of imaging.
Yes.
Does it from clinical to dermoscopy to trichoscopy. I think
it's all about workflows, right?
It's all about the workflows. But dear friends from the regime management, can you please already launch our first poll? Because I think maybe before we start, it would be very interesting to get a little bit of feedback from you guys. Again, as I said, interaction is what makes these shows so wonderful. And in fact, we have been in the last 30 years dealing with photography, imaging at the level of dermoscopy and clinical photography. And we would like to know in terms of when it comes to static, when it comes to treatments that is not related, let's say, to mole mapping, to what extent do you guys use technology? How do you use it? I mean, is it what kind of technology do you use in your clinic? It's very interesting to hear that and to evaluate it, because after the session of Ahmed Sadek, I think we are going to go together and evaluate these poll with the questions that we share here with you. I think they allow us to understand a little bit better your way of working. I mean, your workflow in your clinic.
Yes, yeah, and yeah, we will talk about how you can be more efficient with your workflows, save time, and yes, it's interesting to know how you work.
Exactly. So before starting the session, I was just telling Katrin, the clinical photography in daily practice has got obviously many purposes, legal purposes sometimes. Of course, marketing purposes. I mean, if you look at Instagram and other social media networks, how clinics prove the added value and the success of their treatments by good photography. And we will talk about that, because it depends really on how you do the photography, depending on what you want to highlight, vascular issues, pigments. And that's why I'm really happy that you guys are participating in this poll. We designed 4 questions that allow you to tell us your opinion. I will have a look at it. Meanwhile, you are watching the great presentation of Dr. Ahmed Sadek from Cairo.
Let's start.
Let's start that wonderful session.
Good afternoon, everybody. I am Ahmed Sadek from Egypt, and I'm glad to be with you this afternoon during this FotoFinder online webinar. I am going to be talking about hair and skin imaging, my 20 years experience, tips, and tricks. Sorry for not being able to be live with you because of other commitments at the same time. Okay, well, first, this is our hair and skin imaging unit at the hospital, which I manage. And this is when you are meeting many patients who have diverse needs, including full body imaging, specific face and other parts of the body imaging, trichoscopy, video dermoscopy as well. But if you are not in such a very big setting as the hospital, this is how I have arranged a specific part for cutaneous imaging in my private practice, where I have this specifically dedicated room for skin and hair imaging. And as you can see over here, I have a working station with the computers, the facial aesthetic solution, the Medicam, and I also love all the gadgets that are brought with these devices, including the different applicators, different lights that can be used to highlight different chromophores of the skin. And as you can see over here, I have different backgrounds at different distances, and this is fully the image that the patient gets when he enters the room. Okay, this is how I go for the facial aesthetic solution. This is, for example, how we assess the scalp by imaging, and here are the different positions that the patient goes through in order to get the best amount of data regarding the specific area that we want to assess. Over here, you see the interface of the software where we can highlight specific parts of the area of interest, and based on this, we can go for dermoscopy afterwards. So after this brief introduction, we can say that hair and skin imaging is all about objective evaluation of hair and skin using digital imaging to define the nature and the extent of the problem being treated, facilitating monitoring of changes over time with documentations, before and after comparisons, which can be helpful in research, teledermatology, and medical legal scenarios as well. And that traditional follow-up with naked eye and color photography is definitely not enough, because it does not provide quantitative info, and it's also prone to significant inter-observer variability, and that gradual and subtle improvement is usually missed or accommodated. So we need alternatives. That's why I believe that contemporary imaging shall consist of surface imaging and subsurface imaging. And today I'm going to focus about standardized digital photography and dermoscopy and trichoscopy. So let's begin with the standardized digital imaging. We have specific items for that to be done in the most appropriate way. First, we have guidelines. We have to have specific distancing. We have to have fixed lighting. We have to have the same background and the same positioning of the subject. And if anyone can do it on social media, why can't we do it in a professional way at our clinics? We can have some sort of like the studio. We shall have a fixed lighting on the patient, and we can also have 245 degrees lights to minimize the shadows of the backgrounds. The background shall be plain, shall be non-reflective, in order to get the best outcome of imaging. And this is how I perform it, the standardized digital photography at my clinic, as you can see over here, using a DSLR camera, a tripod, and the lighting. And as you see over here, how I go for the zoom and the focus on this area of interest, how I do specific tips for assessment of specific parts of the body, and how different positions we can go for specifically for the patient. And this is how I manually adjust the zoom and go for the autofocus. So for standardized photography, we can have the simple compact point and shoot cameras, but I don't recommend those, in spite of being cheaper, lighter in weight, but they get less quality. So if you're going to have a camera, it shall be a DSLR camera. And in order not to think that this will be difficult for you, I recommend that you go for 3 limits of exposure to have them adjusted for the best quality. First, you go for the shutter speed. You get the lowest possible shutter speed in order to get the highest precision, as you see in the images, because when you have shorter shutter speed, you get much more details, so there is blur. And for the aperture, get the smallest aperture opening, because this lets you not capture the details of the background. You capture only the details of the subject of interest. And for the ISO, go for the highest sensitivity for the best quality of pictures. If we go, for example, for standardized positions and we want to assess the scalp, for example, here are the 4 positions that I recommend for the scalp. And for the aesthetics of the face, I recommend 5 positions: directly from the front, 45 degrees from both sides, and 90 degrees from both sides. And by this, I have assessed many patients for the dermoscopic photo aging scale with the combination of photography and dermoscopy. And for those who are not aware of the dermoscopic photo aging scale, it assesses 11 items for photo aging at different 4 areas of the face to have a score of 44 points regarding the photo aging. Here are images of some of my patients, and with following this up, I've noticed the following. As you can see, this is a patient suffering from photo aging, and here are 2 dermoscopic images. The one on the left is using cross-polarized light, but the one on the right is using non-polarized light. And what I noticed was that on the left, we can find the details of the pigmented lesions clearer with the cross-polarized light, but on the right, with the non-polarized light, we can see or highlight the wrinkles in a better way. And at higher magnification, it's still the same thing. For other areas of the face or the body, the same thing. On the left, the cross-polarized gives us better detailing of the pigment, but on the right, the non-polarized gives us better detailing of the texture of the surface. I followed this concept and I've assessed many patients with the different light modalities. And thanks to the good quality of light provided by FotoFinder, we could develop something more. Here you can see when I apply the different types of light to my face, and when I go for even more standardization by applying specific points of assessment for the face, and I've applied this through many studies, split face studies, and also by dermoscopy to highlight the differences of the skin, different skin chromophores and different aspects of photoaging. It's not just about photoaging, but also for melasma. We know that melasma is a very resistant condition which needs proper assessment, and we know that there are different histological subtypes that can be assessed by dermoscopy rather than UV, but UV can help as well. And as you see over here, this is a picture of mixed melasma showing the appearance of epidermal part, dermal part, and vascular element as well. That was the classic standardized imaging till I was introduced to this new device, the MISMA. Well, the MISMA is really a very good device, which I was glad to have. And as you can see over here, this is the MISMA. I have adapted my iPad in it, and thanks to the use of different light modalities, we are able to go for assessment of different parts of the body. It's really very easy to use, and here you can see the different lights, the cross-polarized, the parallel polarized, the non-polarized, in addition to the UV light. Here is how I use it in my clinic. You see over here, this is the background, and this is the software that is installed on the iPad. I simply install the data of the patient, and then afterwards I go for imaging, and it gives us also the utility of capturing the the different positions of the face that I've just mentioned, the 0 degree, the 245 degree, and the 290 degrees. And thanks to the use of the different lights, simply by a simple touch on the screen of the iPad, you can see over here that we can switch between the cross-polarized, non-polarized, and parallel polarized. And here you can see the different images with the different lights that we have captured for different patients. And you can see over here on the left how much the appearance of the wrinkles is enhanced with the non-polarized light. With the parallel polarized light, it highlights the vasculature of the face more, and with the UV light that is embedded, it can highlight the pigment. And when the pigment is darker in color, it's more superficial. So this is just an introduction about how to standardize photography in your clinic, and how can you use a simple device like MISMA to capture very high quality of images using different types of light that can really highlight the different chromophores of the skin, identifying its needs, and tailoring your treatment plans with before and after comparisons, which is by way much more superior than classic photography that can be used. The very important thing about the MISMA as well is that it's linked to the hub, the FotoFinder hub, so you can have your patient's data installed, and it's a lightweighted device that you can use whenever you are practicing at different parts or different areas, or you have different clinics, to have it all installed on the same software using the same device. So this is, I think, this is a breakthrough in standardization of photography, especially when also you can get the stand of the MISMA as well. So this was about the skin. What about the hair? Hair loss can be the commonest complaint in our practices, and that's why trichoscopy, in addition to the imaging or the standardized imaging, is important to identify the different causes of hair loss in a non-invasive manner. And for this, I recommend that you use the polarized contact dry dermoscopy first to assess the scales that might be affecting the scalp, followed by the polarized contact wet, and finally the polarized non-contact to assess the vasculature of the scalp as well. But the thing is that where do I apply my trichoscope to the scalp? This is based on the clinical context. So if the patient is clinically suffering from diffuse or patterned alopecia, we first go for central parting of the hair, and then we assess at least 4 areas of the scalp, which are namely the frontal region, the vertical region, and midway, in addition to the occiput as control. If we are assessing marginal alopecias, we first assess the hairlines for the presence of vellus hairs, and then we assess the scales and the peripilar casts. This how we can differentiate whether the cause is cicatricial or non-cicatricial, where we can see the vellus hairs and less perifollicular scales or peripilar casts. In cases of hair shaft disorders which are inherited, we also assess the occiput, brows, and lashes to assess for the same findings. And in cases of acquired hair shaft disorders, we perform the hair tug test and use the polarized light for assessment. This is simply a progressive case of androgenetic alopecia with trichoscopy, where we can see the progressive miniaturization of the hairs and decrease of the number of 2 and 3 haired follicular units. This is how we part the hair centrally, and this is how I get the assessment in my patients, and I can clearly say that this is a female pattern hair loss case. Don't forget about panoramic dermatoscopic imaging, which can be done easily with mobile phones that have panoramic photos, and this is really very nice in assessment of the hairlines. And also don't forget about the power of video dermoscopy in such cases, where here we have captured a head lice, and when we go for video, we can see it even moving on the scalp. So we have different modalities with simple dermoscopy, but this is how I go for video dermoscopy in my practice, how I get the macro images with the Medicam, and then afterwards I go for applying of the markers for specific areas to be assessed. And then I go for dermoscopy, and these are the images that I get, and here are the reports that I give to my patients. That was a few years ago, but with the introduction of the AI, now we have a software that can help us pretty much assess the number of hairs, to differentiate between terminal and vellus hairs, to differentiate between anagen and telogen hairs, and also assess the thickness of the hair shafts to give us a better detailed report, which is more precise and more convenient for the patients as well. Also, don't forget about the enhanced phototrichogram, where we shave an area of 1 centimeter square of the scalp. This is mainly used in research, not in everyday practice, but then we go for further contrast by dyeing the hair black if the scalp is fur in color, and applying hydrogen peroxide to the hair if the scalp is dark in color. And then I assess after 3 days by trichoscopy, and then I compare day 0 versus day 3. The hairs that are growing in length are anagen, but the ones that are not growing in length are in the telogen phase. So this is very good anagen to telogen ratio, and very good for before and after comparisons as well. So this is the basic trichoscopy, how I do it in my practice, and let's go for some scenarios of application of trichoscopy in our everyday practice. In the first scenario, you can be really clinically confident, but just to make sure. For example, in this case, female patient, adult patient, suffering from this focal circumscribed hair loss. And as we can see over here, this is clearly a case of trichotillomania, with the hair being cut at different length, with many black dots, with fragments of hair powder, with the candle sign, and also little subcorneal hemorrhage as well. In second scenario, we can have multiple clinical differential diagnoses, and we are looking for the true one. For example, in this 72 years old male patient suffering from initially he presented suffering from generalized hair loss, but when he was assessed, we found that there are focal areas of hair loss, and looking closer, there appeared that to be some sort of plugging of the scalp, and this is one of the most beautiful images I've ever captured for trichoscopy. And you see that we can find all these signs of DLE of the scalp on the right bottom side at the 4 o'clock and 5 o'clock. Over here we can see the beautiful follicular plugging with initial cicatrization and arborizing blood vessels, but over here we see the late signs of DLE where there is full cicatrization and total loss of hair follicles. In the third scenario, we can see clinically similar cases, but dermoscopically are different, which I like to call twin cases. And here is an example of two heart-shaped alopecias. One is congenital, one is acquired, and the one on the right is the acquired one, where we can see the black dots, yellow dots, the codability hairs, and the eye hair, and the micro exclamation mark hair. And this was a case of alopecia areata. But on the left, this was the congenital case with all those radially arranged seen through hair bulbs that are seen in the case of alopecia plagia cutis congenita. This is really characteristic for such cases. In the fourth scenario, sometimes there are rare discoveries like this frontal triangular alopecia of the scalp. It's not congenital temporal. This is congenital frontal triangular alopecia of the scalp in this 10-year-old female patient. And as we see over here, there is just vellus hair all over the lesion with total absence of terminal hair dating since birth. In the fifth scenario, sometimes dermoscopy reveals surprising findings, such this case of a 60-year-old female patient who presented suffering of this progressive patterned hair loss. And when I compared the frontal region to the occipital region, I found that this is a case of androgenetic alopecia presenting in a male pattern hair loss in a female patient. In the sixth scenario, sometimes clinical dermoscopic correlation builds up. Like this female patient, she was 52 years old. She was suffering from generalized hair loss. But when I started assessing the scalp, I saw that there is marked hair loss with erythema of the scalp. And when I got to dermoscopy, I found those sheaths of scales, peritubular scales surrounding the corkscrew-like hairs. And actually, this was a case of zoophilic tinea capitis in an immunocompromised adult female patient. And in the seventh scenario, sometimes you can be misled by dermoscopy but saved by pathology, like in this case, where this was a 4-year-old female patient suffering from total loss of hair, or actually the hair did not erupt at all since birth. And actually, this was all what I could see by dermoscopy, just hair stumps embedded in the scalp. And by pathology, this was a case of keratosis follicularis spinulosa decalvans, which I could have never told by dermoscopy. In the eighth scenario, you and your team can go for choice of treatment or follow up by dermoscopy. This is a case of 8-year-old boy suffering from alopecia totalis, and by dermoscopy, we could find remaining hairs over there, so we can go for treatment, because this is still not a case of cicatricial alopecia, because when alopecia totalis is longly active and stays with no eruption of new hairs for like 3 to 5 years, I think there will be no hope of recovering the hair in a medical way. By this, I end my presentation, and I invite you all to join us for the International Dermoscopy Society. This is our website. You can join us for free, and I also welcome you and encourage you to submit your articles to our official journal, Dermatology Practical and Conceptual. We have an impact factor of 2.7 right now, and definitely join us in a few days for the 6th World Congress of Dermoscopy in Buenos Aires. Thank you for your attention, and hopefully we will be meeting in person soon. Thank you.
Wow.
Very nice presentation.
No, it's the diversity. I think the audience could see that Dr. Sadek is using imaging, at both levels, the dermoscopic and clinical, in his daily practice. And based on what he always also presents in his lectures, I can see that the enthusiasm grows because he gets the patient feedback. The patients love that.
Yes, absolutely. And as you could see, he has a really nice setting. Yeah.
Yeah, I mean, he has got basically everything that he ever produced.
Exactly.
All the
exactly.
technology. All the technology.
You need some space, and yeah, our poll showed that most of you guys are documenting with iPhone and iPad, right?
Yeah. I mean, we will talk about this because I suppose once we have Pablo with us, he just arrived at his hotel. That's excellent. So let's see if we can get Pablo also listening to you. Pablo, how are you today?
Hello.
Hi, do you listen me properly?
Perfect.
Yes.
Sorry for the delay. I just arrived to Sweden, and I took the taxi as quick as possible to arrive to the hotel.
No, it's excellent to have you here with us, Pablo. Thanks for accepting our invitation. Pablo, when at FotoFinder, when we talk about aesthetic photography, your name is always kind of mentioned, right, Catherine?
Always. from the beginnings.
We learned a lot from you and from the way you use this in your daily practice. Tell us a little bit, Pablo. Tell us a little bit, how did this happen? When did you start to implement photography in your basically workflow of treatments?
Okay, so probably like majority of my colleagues, I started focusing on injectables and technology. So was very involved with the industry in the past, being medical director of Candela worldwide 20 years ago. And for me, the most important thing was to treat properly the patient. So to have the best device, the best protocol, and to achieve the best results. I think now that I committed a huge error. So the sensations the patient has related with the result of the treatment is as much important as the real result we have in each one of the treatment sessions. That means if we don't prove them the benefit of the treatment in each one of the sessions, the patient will never be happy. So I took many years to learn about that. So I spent a lot of money on very expensive lasers. Now I have 58 lasers in the clinic, top brands, looking to the best treatment, the best technology, maximum energy, best results. And I didn't take care of that, about the sensations of the patient, about how they feel is realistic, the sensation they have. So the reality is majority of the patient expect 100% of the results in each one of the sessions. And this is not real. We don't achieve in any treatment in dermatology, aesthetics, medicine, this kind of results. So we need to prove them that we are in the good way. So I started doing pictures with FotoFinder, I don't know, my friend, probably 10 years ago, 12 years ago, so a long time ago. I started with the ATBM just for the dermatological application, the trichoscopy, the dermoscopy, but I really didn't take care about this photography. So I was trying to take pictures in my clinic, my nurses, with regular Canon photography. And we never achieved to convince ourselves and the patients that the work we were doing was the proper one. Why? Because it's so complicated to take a good picture, a realistic picture. So the good light, the good position, the good distance, the proper parameter of the Canon camera. So I would say it's close to impossible to reproduce the same conditions. And if we don't reproduce the same conditions, we cannot prove nothing to ourselves and to our patients. So since I applied the ATBM camera for the facial pictures and corporal pictures, and we standardize the picture. So probably, I know if our colleagues know, but the camera is able to do automatically everything. So we have like a shadow, the position of the patient should be exactly the same one. The camera reproduces exactly the same parameters. Depending on the area we choose, the device choose a specific protocol with light, with flash, or without flash. And I will prove you how it's so important to take pictures with or without or both, because it's the key to prove that we're going to have a good result. And it's the key.
Pablo, this what you are saying is, in my opinion, I must be honest, when I heard this first from you 10 years ago, I thought you are speaking a language that I just don't understand, okay? Because I did not really know what exactly you target. And I must be honest, today we prepared a setup here because maybe today's academy is a bit different from the academies that very much focus on skin cancer, because today we have the chance having Pablo here and in live with a sample patient that we prepared, our great cameraman behind. We will talk about the different types of photography. And Pablo, this insight, this feedback from your side actually managed to influence us in the development. And we will talk today about a device which actually solves one very, very key problem that you always mentioned. The FotoFinder is in one room in your clinic, and you are doing treatments in many, many rooms. And you always told me, Moa, the problem is the ATVM needs a space, and I cannot put 3 ATVMs in 3 rooms. It's impossible. Solve the problem of a space. And this is something that within the next 45 minutes together, we will discuss in detail. We will, of course, at this moment, maybe also grab the device, go into live photography and having your comments while we work with lights, Pablo, because this is a great introduction to your presentation, I know. And I think for the people to understand how light changes the view on the skin texture, we simulated in live in this academy. Okay, how do you see that? I have the device, the portable photography device. I know you don't have it yet, and I know that you are waiting for it. You will get it. But I think we will today play a little bit with it, because it will allow us. Let me just share my screen. It will allow us to explain the audience what is a standardized photography in a portable, fast way, and how it can create an added value to our daily practice. This is what many of you might know already from your FotoFinder, your database. This is where you can find your patient's data. So you can search for your patient's data, and the FotoFinder allows you to have access to that. Once you enter the software, you see all the pictures that you have taken before and after. But I would like in live to have Pablo with us talking about the lights, because the lights that I will show you now are exactly what Pablo over the years has been asking. I am now in a live image, and I will ask my colleague to join us. And Pablo, you will maybe comment this in live at the same time. Maybe your profile, that would be even better. Perfect. So Pablo, this is now a view without any light. You see that?
Yeah.
So yeah. Now I activated the MISMA, and we start with a neutral light. That means with maximum light on the skin. See what happens. So can you please comment this when we work with maximum type of light?
So it's extremely important to take both pictures with and without light. Why? Because with light, we improve the colors in the skin. So if we want to take a picture of pigmentations, melanin, of redness, telangiectasia, cuperosis, rosacea, tattoo removal, pigmented, it's absolutely important to put a good flash on the treatment in the camera. Without that, we are losing a lot of information related with this chromophore, related with this melanin or hemoglobin or tattoo.
So Pablo, what about using X-Polarize? Look, I switched to X-Polarize, and now I can even better see the pigments and the redness. Do you see that?
Absolutely, it's the key. So the patient many times comes, probably like this patient, to treat their wrinkles. So for wrinkles, we need to take out the flash, because we see much better the volumes when we take out the flash. So you have done just now, it's amazing. We see much better the wrinkles around the eyes. So, but it's also important to take a picture with polarized light or with flashlight to be able to see the pigments, because many times the patient are not concerned about the pigmentation. In this case, about, cherry angioma and close to the neck, a spider angioma, some lenticos. And when we take the picture with the flash, it becomes evident to the patient that they have another concern to be treated by us. It's not just the wrinkle, it's also the pigmentation. So when we're able to take both with flash or with polarized light and without flash, we're able to have a real perception of the situation of the patient, and we're able to talk with them about what do you really want to treat. And many times it's amazing for me, because the patient like him comes to be treated for the wrinkles around the eyes. Probably he wants some botulinum toxin, and taking a good picture with and without flash, we're able to treat the patient on other concerns like the vascular or pigmented. So the patient doing the first consultation tell us that they want to be treated on more than one thing. So it's amazing because it's really like my sales camera. So the camera do the job for me. I don't need to be a seller like a doctor. So the camera enable me to convince the patient that we can do many things to improve their skin conditions. So look to that. Now we have flash. So flash and polarize means we see much better the pigmentations and the chromophores. And if we take out, please Moja, take out the polarize, and we see much better the volume. So if we want to treat by injections of diluted, for example, hydroxyapatite on the hands or with botulinum toxin around the eyes, it's the way to do without flash. And when we want to treat the pigmented lesions, vascular, telangiectasia, cuperosis, rosacea, cherry angioma, spider angioma, or even pigmentation, freckles, benign lentigos. So it's important to connect the good polarized lights to see those pigmentations.
Pablo, the reason why I decided to get you in a live demonstration is because the device we designed is providing maximum flexibility. First of all, photography of entire body. Second of all, we have basically 5 types of options: without light, neutral light, which is a lot of basically illumination. We have the parallel polarized for wrinkles, cross polarized, as you see here, for vascularization and pigmentation. And we have got the UV. The UV, in my opinion, later on we will probably dive in a little bit more into the UV, but it's opening a new dimension for us at the level of clinical photography. When you look at what we have here, and this patient came really for pigmentation treatment, but it was discovered only by UV that the patient has got initial stages of vitiligo, not only on the face, but also other parts of the body. I believe UV is opening at the level of clinical photography a whole new dimension at FotoFinder. Pablo, do you do UV photography in your clinic?
Absolutely. So I like treatments on hypopigmentation. I like eczema lasers, 380, 308, 311 nanometers wavelength, but I also like to treat melasma. So I don't understand how 20 years ago I was not able to treat those kind of photographies to really evaluate the benefit of the treatment we do with a good Q-switch nano Q-switch laser or a picosecond laser to see if we need to change the parameter, if we need to penetrate a bit more with a larger spot, higher energies. So we program many times the device depending on the picture we have with FotoFinder. So it's not just a picture for pre and post treatment, before and after the protocol of treatment. We take picture every time the patient comes, and depending on the chromophores we see, we parameterize each one of the treatments with the laser. In that case, for example, Q-switch Nd:YAG laser, Q-switch KCD laser, or for hypopigmentation, the eczema laser. So I honestly say that it's the best way to do a personalized treatment to our patients in each one of the sessions we do. And the only way to differentiate from our colleagues to offer better results.
Yes. No, again, Pablo, thanks for your inspiration. This is the first event that we dedicate to MISMA. Inviting you was for me a must, because the discussions we had over the years, especially in IMCAS, in AMWC, in all of those events that are rather dedicated, you always told me photography must be fast, flexible, and affordable. And this is the solution. We've tried to create an intelligent photography device, a device that comes with light, and you can basically manage it via the app. And the good thing is, what probably we will later on again go into detail with your presentation, the device can remember the type of light and the intensity of light that you used in the baseline. And the moment your assistant clicks on follow up, everything will be preset. And that presetting is something that, of course, the ATBM has been, with guided photography, a master of it, okay? We perfectionized this. Mm-hmm. And now it's available as a portable solution. We will, please stay with us during the presentation of Pablo. We will go case by case, and I really appreciate that you prepared it this way, because there is a lot of education in each case, how you treat it. And after that, I will tell you how you can get one of those in your clinic, and all of your staff will be able to use it, because they are very well aware how to use apps. And they don't need to really be masters in photography or IT or application, because the FotoFinder is finally super easy to use. Pablo, my friend, please share your presentation. Let us dive into your presentation and see you. I know that you have body cases, facial cases, and this is going to be wonderful to look at them and learn from them. Okay?
Okay, perfect. So I will just take a few minutes from your attention, but I will try to share with you how this device, this ATPM, and now the new portable device can change our practice with our patients every day. So let me see if I can, I don't know. I'm sharing properly the presentation. Do you see it? Moha, do you see the presentation? Yeah, perfect. So let's start.
Pablo, your presentation is online and it's fine. It's working perfect.
Okay, perfect. So just start with probably one of the diseases we treat more in our dermatological and aesthetic clinics, rosacea. So should we take picture with flash, without flash, with polarized? So it's extremely important to see the color. So, and the color need flash. So without flash, we are losing the information. So it's the chromophore who need to be targeted. So this patient received one session of treatment with Vivin from Candela, a very good pulse-dye laser, a few years ago. And when he came to the second session, he told me, Pablo, I'm not totally convinced about the result because I still have some flushing effect. So we have done the picture with flash, and when the patient has seen the picture in front of him, he immediately reacted and say, probably I was confused. So can I continue my protocol of treatment of 3-4 sessions? So it's just a way to show you that pictures can change the perception of the patient, but we need to do serious picture. As you said, Moha, it's extremely complicated to repeat exactly the picture in the same condition, same distance of the patient, same position of the patient, same light, same parameters. We have plenty of parameters. There are 3 big ones in the camera, in the Canon camera, but to repeat exactly the same ones. So if the device is able to do it for us and to reproduce exactly the same parameters, we will be extremely scientific when we show the picture to the patient and we show them that the benefit is there and we should continue doing the protocol to achieve the expected results in the patient. So again, rosacea vascularization absolutely need this flash. But look to this papulous acne rosacea. So what is important for us? Is important the color or the volume? So in this case, for me, it was important the volume. Normally, I take both pictures. I like to take with and without flash. With to see the color, without to see the volume. So we cannot see volume if we have too much light, too much flash in the skin. So this is a picture before and after done with the same device, the pulse-dye laser, applied also low-level laser therapy of the treatment after one session without flash. So we wanted to see the volume. Evidently, we add to those patients Dercutan 5 milligrams. We like to treat them with pulse-dye laser. And when the papules are not there anymore, the vascularization, the inflammatory process is not there anymore, we like to treat with non-ablative fractional laser. We want to control also the sebaceous gland, not just by medication with Dercutan 5 milligrams, but also with lasers. And they are totally synergic. We can do both. If you apply very low dosage of Dercutan, of isotretinoin, 5-10 milligrams, it's totally synergic and we can do without any risk in the same patient at the same time. So let's see, and this is very interesting. We talk about rosacea, we talk about the Demodex, we talk about this acar, who is in our skin, who irritates the skin. So in the past, I was forced to do probably like my colleagues, so and analyze in the university. So I needed to do a photis and to analyze in the university. The reality is, I've done only for clinical studies because for regular patients, it was impossible to do. So when we discover that the polarized light enable us to see those, I know you see in the left side, in the before picture, those pink or yellow dots, and in the right side, much less pink and higher number of yellow. So depending on the absorption by the acar, by the sebaceous gland, by the acars of this light, the reflectance gonna give us an information about the amount of acars, amount of Demodex we have in the skin. So this is amazing. So we can do it before each one of the treatment sessions to know if we need to continue with the cream, with the Solantra, with the ivermectin cream in our patients. So many times we say, apply 2 months, 3 months. So we are not sure about how much time should we apply. And it's important to apply the proper time, no less and no more. So here we have the possibility to tell the patient to buy in the pharmacy this ivermectin Solantra cream to treat the Demodex and to apply as much time as they really need. So when the patient come back for the second session of pure dye laser or KTP laser or IPL if you have, so it's important to do again the picture and to see the volume, to evaluate the volume of ACAS we have in the area, to know if we need to continue or not with this Solantra cream. So very interesting. So it's also changed the way we treat the rosacea in the cream in the clinic, and we have much better results now applying the Solantra or ivermectin cream the proper time in our patients. Let's see to these patients when we talk about angioma. In this case, it was again vascular lasers you can do with Nd:YAG laser. The proper ones should be combination of superficial pulse dye laser or KTP laser, or you can even done with a vascular filter of your IPL. This is again one treatment sessions. We need to combine also with a bit of CO2 for those areas who are more volumetric, but it was important for me to see the volume, not just the color. This is the reason why I took this picture without flash. So I needed to measure the volume to know if I should continue with the same protocol of treatment in the next session. So if they have volume, I like to treat with Nd:YAG laser. We have a lot of vessels in the skin, in the dermis, in the subcutaneous, and we need to coagulate with the most powerful vascular laser we have and to penetrate as much as possible. As you know, Nd:YAG laser, 1064 nanometers, is the wavelength, the laser who enable us to penetrate more and to coagulate more. But the problem is if you start with this patient with the Nd:YAG laser in the first session, after the second session, look to the right picture, you cannot continue anymore with the Nd:YAG laser. You should change to another technology because the deeper vessels were already closed, were already collapsed, coagulated. So now we need to move to a more superficial laser. So it enables us to know if we should continue with the same technology or we need to continue with a technology which is more superficial or deeper, even if both are vascular lasers. So melasma, probably, again, the second skin condition we treat more in our clinics. This is not polarized. I know since I have polarized light, I apply the polarized light, it's amazing. So we need to know, our melasma is epidermal, is dermal, is mixed. Do we have vascularization behind the pigmented lesion, behind the melanin? So it's absolutely important to know. We know since 2004, it was a very amazing presentation in INCAS Congress at Paris 2004, a dermatologist who started his presentation talking about his experience in 100 patients with melasma. And it was nice because he started putting picture before and after. I didn't say how he treated. The results were amazing. And the people became like scared, like ugly with him. So what have you done to those patients? And he said, I've done a vascular laser. So we discovered at that moment that 70% of our patients who has melasma has huge amount of vascularization behind the melanin. If we are not able to analyze and to evaluate this vascularization, we are going to commit an error if we go directly with a pigmented lesion laser. If we go to an IPL or we go to a Q-switch, we should apply a vascular laser before. And then we need to analyze the pigmentation of the melasma is epidermal, is dermal, is mixed. With the polarized light, we can have this information. So we can program our Q-switch Nd:YAG laser or picosecond laser with a larger spot to penetrate more or to a smaller spot to be more superficial. Remember, larger spot needs normally less amount of energy because we target easier the chromophore. And when we go more superficial and we apply instead of the spot of 5, 6, we move to the 3 millimeter in our Q-switch or picosecond laser, we need to increase the fluence, the energy. So we are able to analyze in each one of the sessions which one are the condition of the patient, and we are able to move to the proper protocol of treatment, the proper laser if we need to change, or the proper parameters in the same laser or IPL to achieve the best result as possible. So sorry for that. Both pictures are taken with flash. They say before no flash, after with flash. Both are taken with flash. And the results is when you are able to really personalize the treatment, the results are amazing. Here you have a post-inflammatory pigmentation. Again, we don't treat every day because we have a lot of patients who are from Latin America, and it's true that in those skins it's much more easier to see those post-inflammatory pigmentation in area where, in this case, the patient has previous melasma, previous acne, acute acne, but many times after surgeries or treatments who are not the proper ones. I see a lot of post-inflammatory pigmentations in Arabs or Asian people or Latin American patients who have received a treatment with IPL, with wrong parameters, in the wrong skin, in the wrong treatment. So again, this is a treatment with flash, a diagnosis with flash, pre and post. Why? Because we want to evaluate the amount of pigmentation. And if you are able to add the polarized light, and I will ask you again, my friend Moha, when I finish the presentation, to show them again the polarized, we will be able to evaluate the surface, the area we need to treat, but also the technology we need to apply is very superficial. Should we apply a regular peeling, chemical peel, or it's deeper? We should apply an Nd:YAG laser or Q-switch laser or picosecond laser with smaller spot, larger spot. Are we able to treat with a vascular? Do we have hypervascularization? Because many post-inflammatory pigmentation still remains with a high vascularization. And if we don't control this vascularization, we're going to have a rebound and the post-inflammatory pigmentation will come even worse after 1 month or 1 month and a half. So we need to take care of that. We need to take regular picture, polarized picture with flash, without flash. Again, Otanebus. I've done a good diagnosis here, a good picture. No. See, I've done the picture without flash. And it's an Otanebus. For me there, the volume was not important. And you see, when you don't apply the flash, the difference is not amazing. The patient was extremely happy after 3 treatments with picosecond laser, with Q-switch laser. But the problem is the picture didn't prove this benefit. So in this case, if I take the picture without flash, without the proper parameters, it's not going to help me. The picture is going to destroy my credibility. The patient was happy, and the picture I took made the patient unhappy with the treatment. And I've seen that many times in the past without having a camera was able to take automatically all the parameters. So it's better many times not to take a picture if you are not able to do in a standard parameters and to reproduce exactly the pre-treatment parameters and the maintenance and post-treatment parameters in your camera. So again, dark eyes. The patient came. In this case, the patient claimed about volume, not volume. He has dark eyes, and we showed the patient without flash that there was a lack of volume, and with flash that there is an excess of pigmentation. But you see there, we choose the without flash, the picture without flash, because the pigmentation was very low. And it's nice. This patient came from another clinic from the south of Spain, from Sevilla, to be treated with a picosecond laser, a Q-switch laser. And with the picture, we convinced him that the problem was not the pigmentation. So was not the melanin. The problem was the vessels who were behind this very thin skin that we see those vessels like pigmentation when they are really hemoglobin in the dermis and subcutaneous tissue. So this was the way we convinced the patient that the treatment was not should not be the Q-switch or picosecond. The treatment should be the one who regenerate the skin. So we can put very low reticulated hyaluronic acid. No, I prefer to do plasma gel, so biofiller, so with their own PRP to gellify 100 degrees Celsius during 10 minutes and to have this gel of PRP, which much more creates a volume and neocollagenesis, and also to combine with fractionated laser. Again, you can combine here. Personally, I prefer the erbium because here you have a lot of vascularization, and CO2 fractionated laser can create too much risk of post-inflammatory pigmentation. But here, an erbium fractionated laser who have much shorter pulse duration and much less risk of post-inflammatory pigmentation in combination with the non-reticulated hyaluronic acid or the biofiller, I think is the key to obtain the good results. So, and again, very nice, like a way to convince the patient that the treatment he claimed to be done by us, and he came from the south of Spain to be done for a Q-switch laser, a picosecond laser, was not the proper one. So we changed the protocol before starting the protocol, and we convinced the patient. Again, lentigo, selenis, décolleté, when we have so many of them, as you know, we like the IPL. We can do with Q-switch, but it takes a lot of time. So this is a treatment we can be done with chemical peels, with IPL, or with Q-switch laser. So if you put the polarized light and you see that the pigment is extremely superficial, you can do perfectly with your chemical peel. And you can personally delegate to the young doctors or nurses in my clinic to do this kind of peeling. So this chemical peel would be enough to have a good result in the patient. We don't need to add the technology. We don't need to charge more to the patient when the benefit will be obtained exactly the same with a chemical peel. Because if you apply the polarized light, here the picture was taken with flash, but again, if you apply the polarized light, you will see that the pigment is extremely dark, so it's extremely superficial. And we can propose the patient a protocol based on chemical peel and not on Q-switch laser, or combination of chemical peel and in the second session, an IPL for all the area. Lentigo solaris. Again, this picture was taken without flash. Huge error. So if we want to evaluate the pigment, we need to apply the flash. But why should I show you this picture without flash? Because I also wanted, during the first consultation, to convince the patient that with the treatment of pigmentation, it won't be enough because they have so thin skin. So we see so much atrophy in the skin that we see the tendons, we see the vessels, we see the veins who are behind the skin. So we can start with an IPL or a chemical peel, but we should move after that to a skin regeneration with, I personally like the diluted polylactic acid or diluted hydroxyapatite, radies, I apply in those cases, diluted, like a way to stimulate the area. Now you can apply, as you know, those polynucleotides, melanosome. So there are so many treatments you can apply, but this patient receive a treatment with chemical peel, and then I convince the patient in the second session to move to a skin rejuvenation in the hands with injection of hydroxyapatite diluted by cannula in the hands. So micropigmentation. So we do a lot of micropigmentation in Europe. So we don't treat as much tattoo removal. In tattoo is very common to do the tattoo removal in USA, but in Europe, in the south of Europe, we do a lot of micropigmentation removal. So all those women, sometimes men, who pigment the eyelid or the pigment around the lips or pigment the eyebrows. So we need to remove that. We need to convince the patient that we can treat without damaging the hair. And when we apply a Q-switch or we apply the new picoseconds ND-YAG lasers, we are able to remove the pigment without any risk to the hair. And we can prove the patient the hair you had at the beginning of the treatment is exactly the same you're going to have after 1, 2, or 3 sessions. This is a treatment we have done with Q-switch and the YAG laser. Why? Because you see the pigment is dark. So the pigmentation was black at the beginning, and when we shoot it with the Q-switch and the YAG laser, it becomes lighter, but you see this color who is like orange. So it's the moment to change to a Q-switch KTP or a picosecond in KTP, 532, not like ND-YAG laser, 1064. If we don't change the wavelength of our laser, we commit an error because we have risk of creating post-inflammatory pigmentation, and we are not going to remove the pigment because the chromophore has changed. It's not anymore dark, dark color, it's lighter, it's orange. So when we take a proper picture, and I can promise you that many times if you don't take a good picture, your eyes give you bad information. So taking a good picture, we evidence that the treatment needs to be changed. We need to change to a Q-switch, KTP, or picoseconds KTP laser. And the reaction will be different, and we prevent the patient. You know, now we're going to have less edema, but we are going to have more risk of purpuric reaction. So please take care about the sun because we have more risk of post-inflammatory pigmentation. So we're able to change the treatment, to change the Q-switch from Q-switch ND-YAG laser to Q-switch KTP, and to prevent the patient about the risk because we evidence that we need to change the wavelength of the laser. And the patient needs to see also that, to understand that we have the ability and we have the technology in our clinic to continue giving them more benefits, but changing the technology after this session of treatment. Very nice patient with gunpowder pigment elimination with a gun. So it exploded in his face. So in Spain, we have a lot of people who like to go to the outside to kill some nice animals. So I don't agree with that. And sometimes they are not too professional. And in this case, the gun exploded in the face of the young man. So important to evaluate the pigment. Important to evaluate if you put here the polarized light, you will see that we also evidence how deep is the pigment, but important thing also to evaluate the color. This is the reason why we have done with flash instead of without flash. The pigment was very deep. It was not superficial. It was intradermal. No sense to do here the picture without flash. We need to apply the flash to evidence the amount of pigment we have in the dermis, intradermal. The treatment has been done with a Q-switch. At that time, I done with a Q-switch. Now, evidently, I will prefer a picosecond ND-YAG laser to treat this patient, or a picosecond 755 nanometers Alexander laser to treat this kind of skin. Xanthelasma, should we do the diagnosis with or without flash? Polarized light is no sense there. Without flash is the key. If we put the flash, we kill the volume. So we need to do the picture without the flash. And you see how good taking the picture in a good program with a good parameter and reproducing exactly the same position, the same distance, the same lack of light in the room, the same parameters in the camera, we evidence exactly the benefit of the treatment, and we are able to do even a second treatment on this very low amount of xanthelasma was remaining in the internal part of the area. So nevus, we know, complicated situation. I have many colleagues who doesn't like to treat them because we know that they are deep and they're going to reappear. We have 70% of possibility of reappearance in the next years, but there are many patients who accept this situation. Okay, I accept that they can have in a deeper level some fibrotic tissue, that it can reappear, but I want to remove as much color as possible in this pathology. So when they are flat, we like to treat them with Q-switch or picosecond laser. When they are not flat and they have volume, we like to treat them with CO2 laser, erbium laser, plasma technologies like Plexer, so very good treatment technologies to remove them with less risk than a regular electrocoagulation, who can create some retraction, some collagen type 3 retraction of the tissue, and some risk also of post-inflammatory orientation. In this case, it was a flat one. We treated with Q-switch KTP laser in that case, because it was a light skin, so not too much risk with a Q-switch KTP, much more absorption by melanin with KTP laser than Q-switch KTP than Q-switch ND-YAG laser. And you see after one session, taking the picture with flash, how good were the results. So scars. In scars, it's important. Do we want to treat the color of the scar? Many times we have this vascularization around the scar or in the scar. Do we want to treat the pigmentation, the post-inflammatory pigmentation who is in the scar, or do we want to treat the volume? So important here, again, this patient was concerned about the volume, the rudeness, the deepness of these scars, this traumatic scar he has in the left cheek. So should we do the picture with flash, without flash, with polarized? In this case, no flash, because we wanted to evaluate the volume. But very interesting, if you add also a picture with flash, now I do all the patient with and without, to be able also to evaluate the pigmentation, because many times we try to correct the volume to create neocollagenesis and neoelastogenesis. Probably you have heard during the last congress, the last SCAR Congress in Germany, that when we apply an ablative laser, CO2 laser or erbium fractional laser, we create much more collagen and hyaluronic acid than elastin. And when we apply a non-ablative fractional laser, those 1,540, 1,550 nanometers, so we create more, we stimulate the fibroblasts to create more elastin than collagen. If we want a good color of the skin, much better the ablative fractional laser, CO2 or erbium fractional laser. If we want to create a tightening, to reduce the thickness of this scar, we should apply a non-ablative fractional laser or combination of both with the new hybrid technology. Here, it was a treatment done with, at that time, I didn't have this technology, the hybrid technologies, and we applied mesotherapy and chemical peel. I'm sure I will never do again those kind of treatment to those patients. I will directly go to a combination of ablative fractional laser and non-ablative fractional laser in the same treatment session. And then to give them, if the patient like this one has a high phototype, some 500 milligrams tranexamic acid oral to prevent the post-inflammatory pigmentation, and some low-level laser therapy at the end of the treatment, LEDs or low-level laser therapy, much better to prevent the post-inflammatory pigmentation. Infraorbital rejuvenation. What does the patient want? They want to be treated on the colors. You can see that the man has a very small cherry angioma on the right side, or with the wrinkles. Evidently, he came because he wanted to remove the wrinkles, to have much better rudeness on the tissue. So this is the reason we take the picture without flash And in that case, I wanted him to show them that he has also some pigmented lesions, some lentigo solaris. And I took this patient with flash to convince him how good can be to combine both treatments. So treatments on relaxation of the muscle, like botulinum toxin, and in the same treatment session, not spare. I've done exactly in the same treatment session this combination with hyaluronic acid and some Q-switch and the Nd:YAG laser. So it's interesting. Probably you have heard in the last webinar done at IMCAS 3rd of September, there were more than 2,000 doctors joining this webinar talking about combination of techniques in the same treatment. So we don't talk anymore about combining in different sessions. We can combine with safety and even more efficacy many of the treatments we do with injectables, peeling, or light, laser, or radiofrequency in the same session if we know exactly the protocol. Every time do the injection after the laser treatment. Periocular wrinkles, you see before and after, very interesting improvement of the wrinkles. And with this iteration we do without flash. Perioralis lip wrinkles, again, no flash to see very well the code bar before and after the treatment. Local adipose tissue, evidently, we can do also picture of body. Extremely important here. The color is not important. We take without flash because we want to see the volumes when we treat with a cryolipolysis or a focus ultrasound or multifocus ultrasound for the volume. Stretch marks, what do you want? To treat the color or to treat the depression and the thickness of the scar? In this situation, we were concerned about the color. This is the reason why we started with lasers, and then we move to radiofrequency. So we see that we have a high color, high vascularization. We need to try to remove this vascularization, and then, yes, we can move to radiofrequencies, any kind of radiofrequency, or even to non-ablative fractional laser to try to, or intradental radiofrequency, to try to compact those stretch marks. Varicose veins, here you have without flash, because I wanted to see the volume of these the truncular and reticular veins. Those veins are not going to be treated by lasers. They should be treated by soap, by chemical sclerosis, and it was impossible to take them without flash to see the volume before and after the treatment. So I think I finished my presentation. I tried to do it as quick as possible, my friend Moha, but it's just a proof that how a good picture with flash, without flash, with polarized light, but every time done with exactly the same conditions in the camera is able to give us a lot of information before, after, and during the treatment sessions, and to change the protocol during the treatment session. So, okay.
Pablo, excellent. Please accept my gratitude for the cases that you collected, the time that you invested with your assistant. You have got a great team at Elite Laser in Madrid. I know that your team is also very well trained at the level of photography, which somehow assures that this before and after images are comparable. Very few doctors in the events we participate, from IMCAS to EMWC, others, very few are able to show good, proper before after photography. And this is really sad, as you mentioned, that they might do very good treatments, but they are not able to really show it.
Yes, that's true. I have one special question, because you showed also the case that removing moles with lasers, for example, there are lots of doctors in aesthetic medicine who might not have experience in dermoscopy. What do you suggest?
Okay, so I think it's evidently we cannot treat a mole, we cannot treat any pigmented lesions if we are not sure that is benign. So I think the FotoFinder technology enable us to do a lot of communication between aesthetic medical centers and dermatological centers. And this communication, taking properly the dermoscopy, a good clinical history to the patient, and sending to the dermatologist in real time. And I've worked like that, I remember 10 years ago, like that way. So it was amazing, like a way to save the time of the patient, like a way to tell the patient if the patient were able or not to be treated by removing this benign lesion by CO2 laser, erbium laser, electrocoagulation, or plasma technology. But we need to have the information. And the device gives us the possibility to take a picture, the ATBM to take the dermoscopy, and to send in real time this dermoscopy to the dermatologist. We have an agreement to do this evaluation.
Pablo, we realize that obviously over the years we became masters in creating a perfect solution for dermatologists, for especially those who are very good in clinical dermatology. But we must be honest, FotoFinder has always had a very medical approach towards photography. This is the first time we are really creating a kind of new philosophy in terms of photography and going toward more aesthetic photography. But as Catherine said, very often we realize clinics with CO2 lasers that remove a kind of a flat lesion. And what happens is that, I don't know, is Pablo still with us? Or I think he
I'm here, my friend.
Are you here? Okay.
Yeah, okay.
So it happens that clinics with CO2 lasers, maybe not a trained dermatologist at the level of skin cancer, are confronted with a flat lesion, facial lesions on the body. And we were always requested to also provide the intelligent devices in terms of portability also to smaller clinics or aesthetic clinics. That is the reason why we changed our philosophy in development. That we said, okay, we create a clinical device for clinical photography, a portable solution, and at the same time, a portable solution for dermoscopy to use it with AI. And I think for the next minutes, I would like, together with you, to go through the combination, the communication between these two technologies to say, okay, how do we use MISMA for before-after photography, just to wrap up, also talking again, repeating the types of light that you mentioned. And then what is the bridge toward skin? That is the device that is designed for analysis of molds and trichoscopy. So let us maybe, in order to wrap up your presentation, go back to the pictures that I have been taken before your presentation from my dear colleague here, Ani. And Pablo, you would maybe comment, because I took two pictures that I saved in the database. And as you see in the FotoFinder software, we are able to compare before and after when we take two pictures. And we are able to zoom in. So you see that we have got here two pictures. The one on the top is a cross-polarized picture that we took with MISMA. The one on the bottom is parallel polarized, so where we can really see the pores, the skin, the depth. So, Pablo, is this the kind of two standard pictures that you say you always need when you want to go through the follow-up with a patient?
Exactly, Moha. We need that in every patient, in every treatment, in every treatment session. So we need to see the improvement in the color with the cross-polarized light in the upper part is much better than the regular flash, and in the lower part without flash. So in the lower part without flash, we evaluate the volumes, so the wrinkles, the depressions, if the patient has scars, and in the upper one with the cross-polarized, we evaluate the vascularization and the pigment, and we're able to see diseases like small cherry angioma, small lenticles that we cannot see in the lower picture without flash. So with this information, we're able to create a protocol of treatment for the patient. So what do you prefer? Normally, when I see pigmented lesions, I try to convince him to start by the pigmented lesion treatment because the results are much more quicker. So all the treatments related with neocollagenesis, when we apply, for example, fractionated lasers, radiofrequency, intraneedral radiofrequency, takes time. The neocollagenesis take time, 1, 2, 3 months. So I prefer to start with the pigment, even if the patient wanted to start with the volume, and then we try to treat those wrinkles or those scars or those dilatation of the pores. Will take a few sessions with technology.
Pablo, let us maybe go from easy photography toward follow-up. We know that the follow-up can become a nightmare, especially if the tool is not suitable. We having the FotoFinder software, as you see on the top, at the top of your screen, you see that there is written baseline and the next to it follow-up. When I click on that button, you see that FotoFinder gave me immediately the ghost function, and I have now the possibility to go on and do the photography of follow-up. And you see the ghost function allows me basically to put the patient in perfect position for before and after. You see that? And this is, in my opinion, the key to before and after photography when you work with an intelligent solution as the MISMA. Our goal is that even the follow-up picture comes with the same parameters as you mentioned, the cherry angioma, the pigments, and the cross-polarized effect is here perfectly visible. So even the depth of the pigments, Pablo, can you maybe comment this area?
So it's very interesting. Before that, my friend, you talk about putting the face exactly in the same position. In my experience, if we change 5 to 6 degrees the position of the face, when we measure volumes, when we want to see volumes like wrinkles, scars, acne scars, we change dramatically the perception we have on this scar or on this wrinkle. So think about that. We don't see the wrinkles. We see the shadows created by the wrinkles. So if we change a bit, 5 degrees, the angulation, 5, 6 degrees, the shadow is different. And we can have a very good result, but the picture doesn't show us this very good result. So again, my friend, if we do pictures, they need to be the proper one. Because if we don't do in the perfect conditions, they can even create us a problem in a patient who has had a good result. So talking about pigmentation, so are you able to take we talk about polarized light. Here you see perfectly those cherry angiomas the patient has, starting a spider angioma and those lentigo solaris the patient has. So it's evident, and I like even to count, it's a bit of marketing, but I count the number of vascular lesions and I count the number of lenticos just for the patient for them to be evident that they have a pigmented lesion situation that can be improved by us. So again, if you take that with a regular flash or without flash, you will never see this amount of pigment. So the darker ones are more superficial, the lighter ones are deeper. So higher pigment, the more superficial pigmentation is seen in a darker color, deeper one in a lighter color.
Okay, I believe just to summarize quickly the different types of photography that you mentioned, because in my opinion, maybe something that is really very much related to your knowledge, Pablo, is when you explain the different types of photography, I would like to just make sure that that our users exactly understand what you said. This is now without light. Okay, this is just a picture with a room light. Okay, and with the MISMA device, we are able to just select the types of light you see on the right side of the screen. I will now activate parallel polarized, and immediately we see a lot of basically depth and pores because it's parallel. When I switch to X polarized, which is cross polarized, suddenly we just go away from the wrinkles toward the pigments, and the fact that as Pablo said, we can really define the angle and make sure that we take the picture as it is necessary for a before and after. And we are able to cover the entire body. I mean, we can take the neck, we can take the arms, and this flexibility, in my opinion, is very important. Another tool, Pablo, that we integrated here is the type of, in here, I have the possibility to use the application in order to basically get myself a kind of a guide when I do the photography. You see that? So this guide allows me to do the 90 degrees, and it allows me to better guide the patient toward the photography. So we have got here templates, before and after templates for face and also for a scalp. We will maybe this is a good introduction to move slowly toward photography of the scalp and also trichoscopy, which is more and more becoming very important for the clinic. So I would like to show you the effect of cross-polarized photography. Look at this. This is when we go with normal photography, we might not very well see the details on the scalp. But the moment we switch to cross-polarized light, we can perfectly see the scalp condition. And in my opinion, this is also another important factor when we talk about scalp photography with cross-polarized light. So I'm just saving this here. As you see, whenever I take a picture from our patient, the software allows me to dedicate it to a certain treatment. Pablo, let us quickly listen to you. I saw that you have one room dedicated to trichoscopy in your clinic. Can you explain what treatments of hair you are offering in your clinic?
So I started 10 years ago offering surgery to my patient. We moved from the FUS technique to the FUE technique, hair by hair, trying to compete with Turkey. In Europe, we have Turkey, who took the huge part of the volume of transplantation by FUE technique. We started by that, but it was nice to see that the volume of women who didn't really need a surgery, but just a rejuvenation of the scalp was growing very fast in my country. I can tell you now that 10 years ago, I had only, I don't know, 1-2 consultations per day on hair redensification for women. Now we have more than 50 consultations per day on regular women, 30, 35, 40, 45 years old, concerned about the hair. They are not really losing the hair, they are decreasing the thickness of the hair. And it's complicated for them to understand. You are not losing now, you are just on the way to lose, and we can help you. So with this amazing trichoscopy we have with the ATBM, we are able to evaluate if we have any kind of, you have seen the previous presentation, concern in the scalp, in the hair. To put
Pablo, you are entering a very interesting field. Because I want the audience to just follow us while you are talking, and that's why I'm gonna ask Catherine to help me with showing you guys what we have got here, which is I'm gonna do a live presentation of a skin as a trichoscopy tool. So when you turn on skin, you are able to have immediate photography. You see that? So you are able to let me just do it like that. Perfect. So you can see this. So we are able to do a photography of pigmented lesions. You see that when I take now this picture is let me see. Okay. This way. Okay. That's good. That's how you can see. We are able to basically do an AI analysis of it. The AI analysis gives us a score of malignancy, Pablo. So maybe if I turn it like this, you can better see it. Perfect. Okay. So you guys can see that this lesion is a malignant lesion because it's in the green area. Okay. Now, imagine that we want to count the hair here. I just switch from the AI tool for mole toward the AI tool for hair. And it just goes counting the hair, as Pablo said, and gives us very interesting statistic. As it is on my arm, we see that we have a large number of very vellus hair, very, very thin hair. And we have got obviously only single units. So this is very interesting.
Brand new, right?
This is just out. I mean, it's the first time I'm showing it. And we can see the average thickness of hair, which is 23 micron. And this is, in my opinion, I will try to show this to you based on based on a real case. Let me just get you some cases of patients.
Hold it like this, maybe.
Thank you. Catherine, you are helping me with a good. Catherine is here today, helping me with
teamwork.
Yeah. No, because in the end, what I want to show is the real trichoscopy image. Look at this picture that we have here. Okay, the picture allows us. This is a good trichoscopic picture. That means the hair is well parted. You see that the hair is perfectly parted. And when we click on the analysis allows us now to better count the picture. That means we see here now that 93% of the hair is very thick, is above 50 micron. This is this bar. We have an average hair thickness of 95, and we have 86 hair per square centimeters. And the hair units are divided in single hair, in double, and in triple. This is just taken. This is an AI analysis of this picture. And in my opinion, the combination of a good image, simple to take, and analysis tools on a device that is absolutely, I mean, mobile. As you see, I can take this device and just work with it as I like, and work on the scalp, on the skin. And the moment I freeze a picture with this button, I am able to analyze it. Pablo, thank you, Catherine. Pablo,
let me say something, my friend. So it's so important to know the thickness of the hair. So in my experience, when we have less than 30 microns, eyes cannot see the hair. But we can help this hair. So when we have less than 30 microns, the attitude needs to be on the vessels. So minoxidil, oral or topical, but also there are some shock waves who enable us, radial shock waves, to create neovascularization or magnetical field. So when we have more than 50 microns, many times the vascularization is not enough. We need to increase the thickness of the skin. And then we need to change to treatment like injections of exosomes or fractionated non-ablative fractional lasers or intraneedral radiofrequencies. So we are going to determine the treatment we are going to offer the patient to increase the thickness of the skin and the vascularization depending on this diameter of microns, less than 30 microns, 30 to 50, or more than 50. And the treatment we are going to offer the patient, evidently, we are going to give them oral finasteride or dutasteride or injected dutasteride if we have an hormonal problem. But taking out this part of hormonal alteration, what should we do? To increase the vascularization, to increase the thickness of the skin? For me, the thickness of the hair is going to determine the protocol we are going to adapt to the patient in each one of the phases of treatment of this patient.
No, fully agree. Look, for us, at the level of optics, at the level of calibration of the optics and training of artificial intelligence for a measurement of hair thickness, this is probably something that has changed completely our philosophy in hair analysis over the years. And I think today, having the possibility to offer every aesthetic clinic, every smaller clinics that might not really be very much dealing with skin cancer, with an intelligent dermoscope. I mean, this is the first class 2 MDR. I mean, Medical Device Regulation of European Union allows us to provide this device as an intelligent dermoscopy device into the market. And this is the first time that we are providing such a device and putting it in the hand of all physicians, general practitioners, dermatologists, even gynecologists. And I think the combination of hair analysis and mole analysis by AI on one device is, I would say, what we call it revolutionary at FotoFinder.
Yes, and it's all cloud-based, right? So you have not the pictures not only on the device, you have it in your space in the cloud.
Which is, Catherine, I mean, it's the point. Imagine, I know that Pablo is traveling as much as I do. And for the fact that there is a patient in the clinic, the pictures are taken, and Pablo can just log in his mobile or in his computer and in a secured way, encrypted images, having access to those images and already give some guidance. That is the future. At the end of the day, Pablo, your knowledge, your experience cannot be cloned. But what we can clone is this technology. We can clone it as much as possible in order to give you guys access to it. Pablo, you see that you influence us inside out with the way you not only consult your patients, you have many doctors in training for lasers, you consulting the industry, not only FotoFinder, but also many others. And I think this is what we highly appreciate. And I wanted to wrap up this session maybe by a final poll, because I would like our audience, when we started this show, gave us very interesting answers about photography. The majority is using the iPhone or at any telephone or iPad for photography. And we know that that can work very well, because with the Misma, I was taking the pictures also with an iPad that is integrated. Actually, this is maybe an important part to say. In the Misma, in the background, is an iPad. And meanwhile, these devices are very good. The only difference is that we secure these pictures, we encrypt them. So we deliver a software that is made for clinical photography in medical purposes. So the pictures are not saved on the iPad or on the phone. We can anytime block the access of the device, which is, in my opinion, a very important part, the security when we save patient images in the local environment of a clinic. So what I want to say, we found out in the first poll that a majority is using their phone, because I think it's just fast. We should agree that we don't have time in the daily practice. Can you hear me now?
Yeah, perfect.
Okay, probably the one mic is dead. So I was just, I don't know until when you heard what I was saying.
Just the last 30 seconds. We lost you the last 30 seconds.
Okay. Look, I believe the future of companies like FotoFinder is to provide full flexibility and intelligence. And this combination will allow us to save time, to save as much time as possible, and in fact, replace the current workflow, which is saving images, private patient images on your phone, on your iPad, and keep them not that secured around inside the clinic. I believe, Pablo, this is something that you have seen also when you train your doctors, right?
Absolutely. So I never told you, but I had a problem like 15 years ago with one of those cell phones was picked from my clinic, and you cannot imagine how many problems I have in a legal point of view to prove that the pictures who were taken with this camera were not going to go to the medias, to internet. So
right.
It's when you has never had the problem, you don't evaluate how big can be the problem if you don't guarantee the safety of those pictures.
True. We have a solution for that. Again, the medical device regulation of European Union is forcing us as a imaging company to provide secured solutions. As you said, Catherine, I think cloud is, we use the Amazon AWS servers, and we know that these are at the moment globally the most secured servers worldwide. And this way we can provide not only intelligent hardware and apps, but also a very secured platform for saving your data. I don't know if the poll is now gone. We have the poll already, I think, in place. Thanks for participating. Your feedback that you share with us is what we need also to make this kind of events better and better. And of course, the quality of the event depends on our friends of FotoFinder Academy.
Exactly.
That all these years are accompanying us. Pablo, you are one of the persons that is always invited when we talk about aesthetic photography.
Absolutely. I think this was more almost a hands-on workshop, and I hope that you guys out there also could take some hints and tips on how to improve your workflow and your photography in your clinic or practice. And what was the last poll? Maybe you can give us the results.
The last poll, what I saw from the feedback is that many are obviously interested to implement the kind of photography units that we showed here. Guys, you will be contacted by us definitely. If you have questions, if you have suggestions, please share with us. Pablo will be again definitely invited, and I believe at IMCAS in Paris we might even offer a live workshop during the IMCAS. That's something that you can register for. Inside IMCAS we have got always rooms that are reserved for FotoFinder users, FotoFinder customers, friends. And we would like to invite you. You will receive invitations for that. You can register. And I think in a live workshop, we will be able to further dive in the details that Pablo was mentioning in terms of the angle of the photography, different types of light. I believe IMCAS is always a good place to get together, right?
Yes, and what I like on IMCAS is the combination of aesthetics and really truly medical approach.
Yeah. Absolutely. Pablo, the last words are yours, my friend.
No, thank you, Moha. Thank you for listening. So as you know, I have a lot of relation with industry, and you are by far away the company who really listen the doctors and who try to improve the technology depending on our demand. So thank you, Moha. Thank you, FotoFinder, for giving me this opportunity to improve my practice and to help me to improve my practice and to have a much more interesting clinic every day with your technology.
It's a great pleasure. We wish you all a wonderful afternoon, a wonderful weekend. people stay safe, stay tuned, and at Instagram follow us, because next week we will have a lot of live workshops in Buenos Aires for the World Congress of Dermoscopy, and of course you might be able to hopefully see us together with Pablo live in Paris.
Yes, absolutely. But before we will have other online academies as well. Next one in November will be with the Trichology Club. So we will have a very nice session, and you can for sure see all that on our website in the academy part.
Perfect. Pablo, thank you very much.
Thank you very
People,
much, everybody.
have a lovely
Pablo.
weekend and hope to see you soon.
Bye-bye.
To the world in Madrid. Bye.